Yeah, we should. So. That's the so we tell us
Hiya, how are you? Yeah, good, thanks. Yeah, slightly stressed.
Camera, so equivalent to that.
People sending me presentations at
Yeah.
12 minutes to. Hi, Reece, you okay? Yeah, good. No need to dress up, don't worry.
Sure, I've got change.
No internet. Where's the internet gone down now?
Looks like, and you can hear it, right? That seemed to be a success.
No, seems to be okay.
Okay, cool.
Yeah.
So it doesn't matter the house, as long as that camera's attached to it, that's the one everyone's seeing, right?
Alex, could you tell us if the Teams link is working okay?
Yeah, seems to be. Yeah.
Perfect. Thank you very much.
There we go. I thought we had the house attached to cameras, but it doesn't seem to be. So we can record from that one, I guess.
Yeah.
That's the next thing to check. Other than that, that's everything you need, right?
I think we're done, yeah.
People see that link.
Yeah.
The presentation, you see
We've
that
got,
link.
we've just got to remember to press record.
Yeah, okay. And when do what sections we use in the handheld mics for chatting? Questions and answers. If you,
What's
I've got the two handheld mics to walk around.
yeah, that'll just be ad hoc because
Okay.
yeah,
Great.
as it
Let me know when. Okay.
yeah, yeah, no, so.
Are you doing it right?
Yeah, you okay?
Yeah, okay. Is that going to help last minute?
No, everything good. Yeah.
That's good, like any day, any sort of run or do anything, and just obviously.
Yeah, give you a nod.
Give me a shout.
Yeah, okay, thank you. Thank you, thank you.
You forgive me?
Yeah. Try not to fuck it up, I think is the phrase I use. Hi guys, you okay? Good.
With my presentation, is it just a case of plug my laptop in, or do I need it to send it to anyone?
Yeah, if you send it to me.
Yeah.
What time are you on?
Um,
Yeah, can you send it to me now then?
Yeah, I'll send it you now.
Yeah, okay, thanks. Morning.
Sit down.
Do you know, I thought it run fast, don't it? I absolutely run fast, but you know, and you go and rubbish things, everything else got one.
Yeah.
Yeah, yeah, all good.
Yeah, PowerPoint and then. Turn the light down. PowerPoint.
Oh, I miss it. Long time no speak.
I watched.
It's been out of your engine.
It does go in. He's only himself and he's helping. Yeah. Everything's.
Is it? Each month, it's one engine.
Oh, no, it's fine, yes, that's the way I do it. No, yeah, it's still good, yeah. Oh, you had it? Yes, yeah. So. The sky means it was really less. Strategy. Well, it's a size of your best. Oh, okay. I'm doing this one. I'm just like. All over. Those things, isn't it? Oh, she's nice.
Me and my in for 10 minutes. Use that, it's the hard one for things like that. Is that
The central contention in my view said for now, but if we're in here and it's quite in here, yeah, go for it. Otherwise, they'll probably be somewhere. Just one thing.
Yeah.
I'm trying to play this video, but no sound is coming out. What's the what's the likely explanation for that?
It seems my symbol was actually quite tricky because of the way they're still set up. Everything.
Right.
3 and 4. That's me.
Morning.
One's 9 of it, very quickly. You've got some cables very fast.
Okay.
Just got one way to the back. And more infrastructure for it. Just make sure your sound out on the settings of your laptop. Is the sound card? I'll come back to that.
Oh, hi, Susie. Yeah, good. Thanks. We may be live on Teams, so careful what you say. You okay? Good. Yeah. Yeah. It's really good having you actually, because we haven't got much in the way of Hep B, so perfect. And the reason I said about tomorrow is I thought you were trying to get your friend to. Was that, yeah, okay. That's why that was a slight confusion, I think. Yeah.
The Teams meeting as well, so it's a shame.
Yeah, if possible, yeah. Hi, Sean, you okay? Good to see you. Yeah, everything all right with you? Hopefully. No, you can sit anywhere. Yeah, go for it. Yeah.
Everything was played harvester. I'll be honest. Yeah, not bad. Just put it on the it sort of sound like a laptop. Use that. You must just have the setup. Just the sound settings on the.
Okay, just 1 second. Did I shut that down? Quit. It was this one.
Laptop sound settings basically. So to go to the.
Oh, okay. Where would that be then?
Sounds on there. That's all. Not in there. As long as it's out. Headphones. Yeah, that should be fine.
This
No,
one?
no headphones. I said no, I'm muted. It's muted at the moment. So.
Oh, okay.
Sy'n gallu arwain at sut
I like you in the light.
Mae symptomau Hep C yn aml yn cymryd amser hir i ymddangos ac mae'n hawdd ei drosi â symptomau afiechydon eraill. Symptomau fel blinder, a meddwl pŵl, croen a llygaid melyn, a hylif yn croni yn yr abdomen. Mae HEPC yn cael ei gysylltu a ddefnyddio cyffuriau fel arfer, ac mae modd ei ddal drwy rannu offer halogedig. Ond mae modd dal HEPC rhyw broses lle mae yna gysylltiad gwaed i waed. Rydych chi'n wynebu mwy o risg mewn safleoedd heb drwyedd yn y DU a thramor. Drwy driniaethau fel microlafni, dermobleinio, electrolysis, tatwyo, hyllu ac acwbigo. Mae defnyddio steroidau yn achosi risg arbennig. Felly hefyd, trosglwyddiad o fam i fabi. Heb braf HEPC, efallai na fyddwch chi'n gwybod ei fod gennych. Felly, gall HEPC fod yn lladdwr distaw. Mae'r praf yn syml ac ar gael am ddim. Y praf safonol yw praf o bus motyn gwaed sych neu braf swob o'r geg. A'r newyddion da yw, mae yna driniaeth newydd llwyddiannus ar gyfer hepatitis C, sef tabledu unwaith y dydd sy'n gwella bron i 100% o achosion, ac ychydig iawn o sgil-effeithiau, os o gwbl sydd gan y feddyginiaeth, sy'n gallu gwella'r firws, ac yn aml wrth droi'n niwed i'r afu. Felly, pwy sy'n gallu cael ei trin? Unrhyw un. Yn y DU, mae'r GIG yn eich trin chi am ddim, byth bynnag bo'ch statws fwadur, dinasyddiaeth, wlad enedigol, unrhyw defnydd blaenorol o gyffuriau wedi chwistrellu, neu os ydych chi wedi bod yn rhan o'r system cyfiawnder troseddol, neu unrhyw ffactor arall sy'n gysylltiedig ar risg HEPC. Os ydych chi'n amau neu gwybod bod gennych chi HEPC, rydyn ni am i chi wybod bod yna gefnogaeth ar gyfer sgrinio a thriniaeth. Felly, rhowch eich pryderon o'r neilltu a rhowch eich iechyd yn gyntaf.
Tonight is a great opportunity to celebrate all that British comedy has to offer, whilst also remembering why we're here. We've all been affected by cancer in one way or another, and last year, the comedy world lost one of our own, the incredible Sean Roth. Please welcome Sean's dear friend, Harry Hill, to introduce a very special
Faint feirysol o hepatitis C ac mae'n gallu achosi niwed i'r afu neu'r iau os na chaiff ei drin. Y newyddion da yw bod HEPC yn hawdd ei drin a'i wella gyda thabledu sydd ar gael am ddim i bawb yn y DU.
And cure the virus. Hepatitis C is a viral infection which, left untreated, causes liver damage. The good news is that Hep C is easy to treat and cure with tablets, which are free to everyone in the UK. However, there are still misunderstandings about how hepatitis C is contracted and treated. Hep C is caught from blood-to-blood contact and, untreated, causes liver scarring, which can lead to cirrhosis and liver cancer. Hep C symptoms often take a long time to show and may be put down to other illnesses, with symptoms like fatigue and brain fog, yellow skin and eyes, and fluid buildup in the abdomen. Hep C is usually associated with drug use and can be caught by sharing contaminated equipment. But Hep C can be contracted in any practice where there is blood-to-blood exposure. You are more at risk in unlicensed premises, both in the UK and abroad, through procedures like microblading, dermaplaning, electrolysis, tattooing, piercings, and acupuncture. A particular risk is steroid use. as well as mother-to-baby transmission. Unless you are tested for Hep C, you may not know you have it. So Hep C can be a silent killer. Testing is simple and free. The standard test is a dry blood spot fingerprint test or an oral swab test. And the good news is there is a successful new treatment for hepatitis C using once-a-day tablets, which are almost 100% effective. And there are little to no side effects from this medication, which can cure the virus and often reverse liver damage. So, who can be treated? Anyone. In the UK, the NHS treats you for free, regardless of your refugee status, citizenship, country of birth, any previous injected drug use, or if you've been part of the criminal justice system or any other Hep C risk-related event. If you suspect or know you have Hep C, we want you to know there is support, screening and treatment. So put your worries aside and put your health first.
You can write down your phone side of the corridor.
Okay.
Thank
Any idea how you stop YouTube going on to the next video? I was just broadcasting the National Comedy Awards for a short period then.
These are on.
Okay, happy?
Hey, hey, yep. There you go, great.
Okay, perfect.
So, any more sound going on your laptop during the presentation?
Only at the end.
At the end,
I've got one thing on the last presentation. I've got a video clip.
this afternoon?
Yeah.
Yeah, I'll unmute it. So I think there's not any team stuff going through. You're not running teams in here, right?
No.
Oh, great, good.
Yeah. Yeah. Okay. Perfect. Thanks.
Okay,
Okay. Perfect. Thanks.
Oh, sorry. Think that I'm to leave.
No worries.
Just dropped my bag over.
What's the loo?
At the end there.
That's what it is, you just
Okay, morning everybody. Morning. Morning. Morning everybody. Morning. Beulah. Beulah. Morning everybody. Morning. When I say morning, what I mean is shut up. Because we're about to start the meeting. Okay, thank you ever so much, everybody, for coming. Welcome to this national meeting. Thank you to Public Health Wales for putting up the money to fund the meeting. It's a really important event. It's a massive opportunity for people to network, share ideas, know what's happening about the patch, and help us move forward towards elimination of hepatitis B and hepatitis C. The meeting is all about everybody out there because you are the people who are doing all the work. As I've said many times, I'm very proud to represent you. but that is what I do. I'm your representative, and it's all of the things that you do that actually drive us towards elimination, finding patients, giving them the care that they need, testing them in appropriate circumstances, helping them access treatment, and delivering cure. So thank you very much. One disclaimer, I've been organising the meeting this year, so it's all going to go to shit at some point. So I suppose it's a good opportunity to mention all the people who've organised it previously, like Michelle and Andrea and Rory, and who've all done a really good job. And this will be your opportunity to just get a feeling of how good they are by comparison. What else do I have to say? I have to say there's no fire alarms planned, so if one goes off, then it's something we have to respond to. If there is a fire alarm, we go out the doors and down the stairs, and then we end up in a back street, the name of which I was given, but when you get there, you'll be able to look it up, because it's just escaped my mind for a second. Toilets at the end of the corridor. We've got regular breaks planned, and I really encourage you to meet up, share ideas and network as much as you can. And of course, this evening we've got a meal planned where some of the best networking happens, normally in Live Lounge at about 2 in the morning. On that one note, I do actually have to disappear at the end of the meeting for an hour, so I'll be late to dinner, but I'll see you all when I get there. Okay, so what is this meeting all about? Well, it's all about elimination of hepatitis B and hepatitis C in line with the WHO targets. And of course, we're trying to achieve elimination in partnership with lots of different people. We have the Hepatitis C Trust, we have Welsh Government, we have NHS Wales, we have Public Health Wales. We then have all of the third sector who are crucial in our if we're going to achieve elimination, liaising and working in partnership with third sector is going to be crucial. And then we also have industry. Of course, you know, without the medication, we wouldn't be for hepatitis C, we wouldn't be anywhere. We wouldn't be going anywhere in terms of elimination. And without the vaccination for hepatitis B and the treatment for hepatitis B, the same would exist. And then we've also got the testing platforms like the KEFID, and we've got the FibroScan, which enables us to determine liver disease severity. And some of the trade are here in the meeting room next door. So I'd encourage you to take some time just to go and have a chat with them and learn a bit about how they're supporting elimination. What is who are we? What are we about? What would I say is our greatest achievement so far is the fact that we're a network, the Bloodborne Virus Network, which was established back in 2010. I think Marion Lyons was instrumental in setting up that network. And what that network has enabled us to do is have a comprehensive approach to treatment of hepatitis B and hepatitis C across Wales. We share ideas, we deliver equitable and transparent care in all of these areas, and we eliminated postcode prescribing. So well done to everybody here for achieving that. So we're talking about elimination. So what does elimination look like? Well, initially when elimination was announced, it looked like this. It looked like a target of 90% of people treated, and our starting figure, which was, we all recognise, not an exact figure, but our best estimate at that time through some amazing work carried out by Noel Crane many years ago, who I understood was testing people in car parks and all sorts, wasn't he, in order to try and get an estimate of the prevalence. And our estimate was around 12,000. And that would give us a 90% target of treating 10,800 people. So these are the elimination targets: 90% reduction in incidence, 65% reduction in mortality, and then 90% reduction of new cases and 90% reduction in deaths, based on a 2015 baseline. More recently, WHO have updated how they're going to define elimination, and that's essentially because they've recognised, I think, that most people don't know what their starting figure is, and you know, as a developed nation with good epidemiological data, we're in a better position than most in relation to that. But we have to be honest and say that we don't know what our starting point was. We've got our best estimate of 12,000 initially. We've done some further work. We've revised that down to around about 9,000, we think, but actually they're all estimates and they're not precise. So there are some new targets, which I have to be honest, I haven't quite got my head around, but I think Josie has. Would I be dropping you in it if I said that you've got a better handle on this and you might be talking about it? No, you are. Good. Okay, fine. I haven't seen Josie's talk, so just trying to make sure I don't land her in it. And other targets here, and you know, we're at an advantage in certain aspects, particularly in relation, for example, to vaccination coverage among children, because we've got good vaccine coverage and we've got good management of hepatitis B in pregnancy. So this is just a short extract of what the recommendations are from WHO in terms of what's required. So what's required is increased awareness, and this meeting goes some way, I suppose, to increase awareness amongst healthcare professionals. Increasing awareness amongst the general population is harder than it might seem. It's not something I'm an expert in, but you know, when you talk to people who are experts, trying to run a campaign that hits the right people and lands where it needs to land is extremely challenging. And people tend to remember very successful campaigns. For example, anyone who's around my age will remember the successful campaign of Don't Die of Ignorance in relation to HIV. I mean, it was very successful in scaring the shit out of me, at least, and most people. And it was very hard hitting. I suppose it depends a little bit on how you define success, because as a 14-year-old boy, I wasn't really that much at risk of HIV at that time, but I was very scared about it. So, you know, is that success or not? It had an impact. But a lot of people don't tend to remember the less successful campaigns, and I can't even name one of them because I also can't remember any of them. But that is the challenge around increasing awareness. So provide funding, and we know, and we could bleat on and okay, no problem. And cry into our beer at night about how we're not getting the funding that we would like and how other people have got more funding than us. But you know, it's important, I think, to recognise that we do need more funding and to keep pushing for more funding and do everything we can to get more funding. But at the same time, we have to think we haven't got more funding, and what can we do with the resource we have? And we are, it's very easy to look at people who've got more than us, but you know, there is an opportunity for us also to look at people who've got less than us and think, right, what can we do with what we have? And what we do have is an amazing team. We have people that are achieving phenomenal things, and today is a lot about celebrating the success of what is happening across Wales, even without that funding. And I did mean to say at the beginning, you know, why are we here? You know, the primary reason we're here is because we want to beat England. And, you know, that's why we're on the planet. So, you know, let's keep that in focus. Universal Hep B vaccination of birth, yes. Harm reduction, we're in a good space in Wales in terms of harm reduction, which is why we don't have quite the same issue in terms of hepatitis C and hepatitis B that other countries do. But there's always room for improvement. So that's something that we can keep driving for. Increased testing, well, it's going up. It needs to go up higher until we've got everybody who's an at-risk individual tested. Only at that point will we know what our prevalence truly was, and only at that point will we be able to say we've achieved elimination. Increased treatment. So at the moment, we don't have any hold-ups in terms of accessing treatment. We do have to make sure that our pathways that are in place across every part of Wales are appropriate for the individuals that are needing to access treatment. And we need to make sure that we have a low threshold for accessing treatment. There are no obstructions in terms of funding for treatment at the moment, so we're in a good space. And come in, yeah, no, it's okay, come in. Increasing, I would love to be in a position to a certain extent where the testing was so high and the treatment demands were so high that we needed to be in a position where we had to increase access to treatment. But at the moment, we're not in that space. Okay, I've covered the other bits. And then within the WHO guidelines, talks about target groups, and I'm not going to dwell on this particularly, but just to say, these are the groups that, as a network, we need to be making sure that we're providing access to testing, access to treatment, access to harm reduction, access to vaccination, access to everything that will improve their health, and which is our job to try and deliver against. Okay, any questions? Okay, so just to recap, we're here to, as a group, to share ideas, celebrate success, network with an aim of delivering elimination across Wales and beating England. Yeah. Okay, one of the ways that everything went wrong for me this year is that I was very late organising the meeting, and then I struggled to fill all the slots in terms of speakers. So apologies in advance, because I think I've ended up with 4 talks, which I don't really want to be doing. I'd much rather be getting other people up here. But yeah, that's one of the ways it went wrong. So you got me again. And then I think not until the end of the day, thank God for everybody. Okay, so current treatment numbers. So you've just seen this, but this is our network. Aneurin Bevan, Cardiff and Vale, Swansea, Haldar, Cwmtaf, Powys and Betsy. That was our original target. That's where we're trying to get to. Now, one thing about treatment figures, okay? So as you all know, our treatment figures are now based on returns via the hepatitis C E form. And nobody in this room can claim they weren't given enough warning about that, because we had about a 10-year lead in, and we went through quite a lot of struggling to get to the point where we said that we were switching off our other recording mechanism, and it was only via the E form. So we're aware that not everybody is doing the E forms, and that needs to change, because that I am not looking at you. You've just got a guilty conscience. And okay, yeah, well, that's the other thing that I'm coming to. So there were 2 potential issues. The first one is, are we filling our e-forms? And we know actually from some of the replies. Come on, guys. Yeah. We know from some of the replies that we're not filling in the e-forms, all of the e-forms. But the other thing is, we need to check that the way we're capturing the data from the e-form, we're not missing anything. So we've got a little bit of tidying up to do in that respect. We've identified one problem, for example, which is if you don't tick the treatment start date, then the computer's got no way of knowing that you've started treatment. They're very annoying computers. They only respond to what you put in and not what you're thinking. Okay, yeah. AI will apparently sort that out for us. Yeah, so that means our treatment figures for the last 2, 2023 and 2024, are perhaps a little bit lower than, or we're not recording everything that we've done, which is important, obviously. So we need to rectify that. Second thing is, right at the very beginning, we were going by calendar year. Then when we had a finite budget for treatment, we had to run a financial year. And now we're recording by e-form. We've gone back to calendar year. So when I show you the next slide, it's slightly, the figures change slightly towards the end. That's not the next slide, actually. This is just to remind you that we have a health board number treated per year and the minimum number to treat per year, which is our target in order to achieve elimination. Now, I'm very confident that if we hit that target, which we never have, by the way, but if we hit that target, I'm confident that we will deliver elimination. We've got a lot of work to do to get there, and we might find when we've done all the testing that we don't need to hit that target. But when people say to me, and it's bound to come up, we don't think the targets are right, my reply is going to be like, prove it to me. And the only way you're going to prove it to me is by making sure you've tested everybody. So whilst we're in a position where we haven't tested everybody, even the people that we've identified that must be tested, then nobody can really say to me the targets are wrong because we haven't got the data to prove it. So we're a long way off hitting our minimum numbers. The closest we came to that was in 2016 and 17, but that was because in that year we had a big backlog of patients who were just waiting to be treated, sat there because they'd been holding on for directly acting antivirals. So that's why we achieved such high numbers in that year. And then, as you can see, up until COVID, we were doing pretty well around the 600 mark, which is pretty good. COVID, we took a massive hit, but kudos to still managing to treat 200 people in a pretty devastating year. And then since then, we haven't quite got back to where we were before, so there's still work to do there. Although, as I said before, some of the treatment numbers are probably missing. On a more positive look at how we're doing, so since 2011, we've treated nearly 5,000 people now. So that's amazing. Nearly 5,000 people accessing directly or some form of effective hepatitis C treatment. And our SVR rate is probably somewhere around 4,600. So if we took that 4,600 with the Wales upper limit, there would be 6,000 remaining to treat in order to achieve elimination. Now, we don't think that upper limit is accurate. With our revised numbers of 8,300, the number remaining to treat would be around about 3,000. Now, it is more complicated than this because you've got reinfections and new infections and what have you. But as a rough ballpark figure, if we take the lower or the revised numbers, 3,000, that would actually be 3 years of work at the minimum treatment targets that we've set ourselves. Now, accepting we're a long way off the minimum target, but this is definitely achievable. And with all of the work that's gone on around Wales, which we'll get to see through the day, if we start sharing all of that practice, if we're testing in probation all across the country, like we have managed to do in pockets, that's going to have a big impact. If we're making sure all of the clients that are accessing drug and alcohol services are getting tested, that's going to have a big impact. So it's definitely achievable. And I think we really do need to focus on the achievability of it. These are some late breakers, naughty people in the room who claim they filled in their e-forms and then at the last minute send me some, oh, these are our real figures. They're wrong as well, are they? Okay, jolly good. So potentially another 77 people over a 2-year period, which would mean we've got only 2,700 people. Done that bit. Am I in the right presentation? Yeah, I am. Okay, so hard to reach populations, and I've put hard to reach because I'm going to talk about that a little bit later. But our hard to reach populations, and I'm just putting it out there for you to think about that for a minute. Which of these groups are we accessing at the moment in your health board? Which of these groups are you working with? Which of these groups could you help us achieve full coverage in terms of testing and linkage to treatment? And where are our gaps within the service, and what could we do to try and start plugging those gaps. So we've got people who inject drugs. That's our, if you like, our major target, because that's the highest prevalence for hepatitis C now. That's our highest prevalence for people with hepatitis C. People from high prevalence countries, again, another very important group, both for hepatitis B and hepatitis C, and we definitely need to do more work in relation to that. Sex workers, street homeless, people in prison, probation, mother to child, and migrants and mobile populations and people affected by conflict and unrest. So I'm going to come back to that in the talk later on today about hard to reach populations. And then just to like wind you all up at the end about what we don't have. And like I said, this is not for us to focus and cry into our beer later about, oh, it's not fair, England have got more than us. But it is also at the same time useful to think, okay, because it's also very easy to get trapped into a sort of a belief that what you've got is what you've got and you shouldn't have anything else. And you tend to, if you like, you know, sort of both things are true, aren't they? One, you can't be too focused on what you haven't got, because that can just depress you and make you inactive. But at the same time, you shouldn't just settle for what you've got, because you've got to keep striving to try and get what you need in order to deliver what we're being asked to deliver. And we're being asked to deliver elimination. And this is what an ODN is, an operational delivery network. And an operational delivery network in England is probably around about the size of Wales. So we are probably an ODN, although I'd argue with our geography, maybe we'd be 2 ODNs, because anything trying to span Wales is very difficult. As you know, when you plug in into your sat nav that you're going from Swansea to Rhyl, and it's 50 miles and it's going to take you 12 hours or whatever it is. That's one of the problems with the geography on Wales. So they have a clinical lead who gets 1 session a week. They have an ODN manager, so a single person whose job it is just to manage the whole network. They have anywhere between 2 to 5 HEPC trust peers who are paid, and each of those peers will be managing some voluntary peers within the community. A core team would tend to be 2 or 3 clinical nurse specialists, maybe, for example, a band 6, a band 7, and a band 8. A ODN pharmacist and an ODN MDT coordinator, someone who's just doing a lot of the administrative work that we don't have. And then on top of that, they'll typically have a fibroscan technician, a project nurse for emergency department testing, a community van driver, extra administrative support, and outreach nurses. So, you know, it's very easy to see why within England you might expect them to be having more success in terms of driving towards elimination. But feel free to use these figures in order to work within your health board and say, look, we're charged with driving elimination. This is how England are funding elimination. This is what we've got, and we do really need extra resource if we're going to achieve what we want to achieve. Okay, so that's the end of current treatment numbers and welcome. Is there any questions so far? Yeah, John.
For that time period, how many have been treated? And the difficulty linking the data, but just in terms of raw numbers.
So there are a number of problems in terms of getting accurate results from that. A lot of work was done around that, primarily in relation to the look back exercise. So the whole idea of the look back exercise was to mine data store, identify people who were PCR positive, and then identify people who were subsequently PCR negative. And we had some rules around how far after the positive it needed to be in terms to try and predict whether it was an SVR or not. So there is that data, and Noel's not here, is he? Oh, Josie is going to present on it. The revised figures, it's more complicated than that. It's looking at a number of different parameters. It went out to a modelling team who used a number of different parameters to put into a model, because they didn't just model what our starting point was. They then modelled how many we needed to treat in order to achieve elimination, and that's that. With our minimum treatment numbers, which we've never achieved, we would achieve elimination by 2030. Of course, we're a couple of years on where we haven't achieved it, so I suppose it's questionable whether we would or we wouldn't. But I'm still reasonably confident that we can, but we do need to just get everybody tested. That's the main stumbling block.
So, do you have a ballpark figure? So for all the new people with positive HCV RNAs, are the vast majority starting treatment? Like 90%. You know how you're having the HIV cascade of care, UNA's 95%.
I don't have that data. Do you have that data, Josie?
The majority of people who are on PCR and referred into treatment are commencing treatment.
Yeah, but we don't perhaps. Josie will be presenting some figures around that. I'm not sure we necessarily have, because of the way the data is collected, I'm not sure we necessarily have a complete map of our treatment cascade. Yeah.
Good boy.
Any other questions? Okay, can you not hear the talk? The questions. Okay, yeah, I'll bear that in mind. Sorry. Yeah, thanks. Thanks, Andrea. Okay, in which case, it gives me great pleasure to invite Danny up to come and talk to us about peer work in Wales and across the UK. Thanks, Danny.
Let's grab some notes. Good morning. Thanks, Brendan, for the invitation to be here today and talk a little about the work that we do in the HEPC Trust, who we are, how we work, and how that's leading developments in the work we're doing in Cardiff and Vale. We've been around for a while, nearly 20 years. Very briefly, the project was set up the HEPC Trust was established over 20 years ago when 4 people with HEPC at that time had no access to decent care, no information. They basically got together to kind of establish an information network for people living with hepatitis C back in 2001. Mindful there was no effective treatment at that time. And very little information, as I said. And our focus is very clearly at the moment around eliminating hepatitis C by 2030. And we're committed to that, and we're committed to find people who are not obviously engaged in systems and treatment and so on. And the way we do that is by kind of empowering people with lived experience to be a part of that process. And I think very much our strength is around our relationship with people with lived experience and having them and their challenges inform the way that we do the work. So this year in numbers, this is last financial year, picking up on Brenda's point, it does chop and change for us to, and this is across the UK, the HEPC Trust work across the UK. Nearly 50,000 people engaged through hepatitis C awareness sessions. We tested 31,000 people that year, typically with DBST, but increasingly using kind of CEPH-EDS. Over 3,000, nearly 3,200 people supported into treatment. In prisons, remarkable across 100 and Lee, how many prisons is it? 100 and how many prisons are we working across? I think 118 prisons, thank you. Tested through high intensity test and treat mechanisms and system and projects. 1,200 of those supported into treatment 1 in prison. We've seen a real increase in helpline. Our national helpline activity has gone up, largely as a result of the infected blood inquiry, which we are supporting. And notably is the 116 peer volunteers. We have around 160 staff at the moment. Okay, but our work is supported by 116 comprehensively trained volunteers, all right, that make a huge difference to the way that we work and how we work. And it's something I'll explain. I'm really proud of that development. Okay, we couldn't do it without our lived experience volunteers. I'm around 90% of our staff. We're a patient-focused organisation. 90% of our staff have lived experience of hepatitis C and/or drug use and/or prison. Our volunteers inform that. We're incredibly proud that 30% of our volunteers go on to full-time employment. One of our biggest two challenges with volunteers, one, finding people, and I'll talk about that in Cardiff terms shortly, but it's keeping hold of people. We train people comprehensively. They have a 3-day induction. They have regular access to all the training the paid staff would have, all the expected mandatory training. They're all given weekly supervision and ongoing support. You know, all of our volunteers within 6 months to 9 months are undertaking level 3, 4, some of them even 5 training. So absolutely delighted in the way they work. We could not, as recognised here by one of our nurses, could not do the work without their input. So as we move forward, building on that success that's been happening, and I think recognising the comments that Brendan made about kind of resources, absolutely, that what's happening is we are clearly building on success. So we are seeing a number of roles and projects that are being commissioned in addition to our, if you like, bread and butter peer support lead kind of roles. ED testing support, the first one was actually in Bristol. That's now becoming established as ED testing. So there's recognition that we're now starting to find people in ED departments, but their need for support is often still there. The original thinking was that ED would pick up on people who perhaps were outside of systems, not needing support particularly, but what we're discovering is that many of those people are requiring support once they're found. Peer-led NSP, we've just been commissioned recently. We started a peer-led needle syringe provision in Hackney, London Borough of Hackney, and we've got similar programs now being developed, just about to be signed off in Liverpool and in Manchester. Increasingly follow me through the gate work, prison community, that's often internal within the trust, but it's also working with prison services, probation and so on and so forth to ensure that that process happens. Key to all of this work is not just the resources that have enabled it to happen, but the partnership work. We could not do this, and I think we're learning that we maximise any of the resources we have by working really closely with NHS colleagues, with third sector organisations and so on and so forth. Peer research and audit, several of our peers, there's about a dozen now that have been trained in social research and get involved in that kind of way. We're doing increased work in probation approved premises. We've got a number of peer leads working in that across our network. More homeless outreach, mobile test and treat. I think we've got something like a dozen vans now that we're working with, mobile vans, when we kind of go out with nursing teams, coordinated by a HEPC Trust kind of peer volunteer, peer coordinator. This is, to me, is a really important development. You know, we've done really, really well in terms of testing people, treating people in the UK. Still a lot of stuff to do, work to do. Prevention is key. So we've got arrangements now into place with all the big major providers, drug and alcohol providers, NHS and third sector, where our staff are able to distribute NSP and naloxone on their behalf. Okay, because often we're out there and doing soup runs, we're working with sex working communities, for example, whatever that may be, late at night, we can provide some kind of access to kind of safer use and advice and guidance. Let's move on. You can see here, I think for me, some of the biggest developments now are advanced testing peers, liver surveillance peers. This is coming from different pots of money. So this is, you know, early detection of liver disease by working with different communities of people. There are now something like 13 or 14 individual commissions to do that kind of work in various areas. Hospital liaison peers, relatively new to us, but I'm just establishing one of those in Birmingham as we speak. Same with Eastern European peers. Is recognition that we need to start tailoring our work, as it were, to kind of communities of people who are very, very much marginalised and ill-equipped to deal with the kind of the pathways that we currently and often have in place. Same with Black and from Caribbean peers. We're developing a piece of work around that at the moment. We recognise it needs to be different. It works very, very different. Culturally, there are different expectations. And finally, here, pharmacy NSP audit. I'm really pleased the fact that our volunteers are key to this, that last year for World Hepatitis Day, we undertook a piece of work to establish where the working community pharmacies were, because there is no clear kind of record. So in any one area, a pharmacy-based NSP is commissioned typically by the drug service, that's subcontracted by the drug service, it's commissioned by the local authority. And there's loads of different mechanisms. We got hold of all the information that was available to us on the NHS websites, accessing all these different services. And out of the 2,500 expected pharmacies, we came down to 1,200 were responding to our calls to say they were operating. There was something like sort of 15%. So, well, we haven't had supply for the last 2 months. A surprising number, you'd ring and go, what's a needle exchange? What's NSP? Well, you'd ring a pharmacy that apparently had been commissioned to deliver this service. So the UK HSA is we're working really close with them now to potentially revisit that audit this year. It's a big, big task, but look, not just about do you deliver, but look at the quality of interventions being offered as well, and the range of services. I'm really, really pleased about that piece of work and how it fits into kind of policy development. All of that work, is supports and informs the work that we're doing in Cardiff and Vale. We were very, very fortunate that last year we were commissioned by Cardiff and Vale Area Planning Board to deliver our peer programme across Cardiff and Vale. And that was a follow-on from the national programme that we had developed in the 18 months previously. Really delighted to have this work into place. And a year in, it's really started to find its feet. So across the last year, and again, that's 23-24 financial year, 806 service users engaged, meaningfully engaged, 156 staff given either hepatitis awareness training, which is a brief kind of hour-to-hour training program, or a full-day BBB training as delivered by our national program. 250 odd staff meaningfully engaged. That means where we have supported staff or staff have called us getting guidance around the people they're working with HEPC, helping understand how to kind of engage people more effectively, how to test, and so on and so forth. 500, really delighted that our numbers of people being tested BBBs is increasing, and that is on the increase. That's increasing almost week by week. Delighted with that. And as a result of that, 55 people referred for support into treatment. The current caseload's around 77, but that's in the last year. Some of those are the legacy from the previous project. We had 59 treatment starts this year that we supported, and notably 58 completions. And obviously, it's not necessarily the same number of the same individuals. What we're clear on now, we're certainly picking up on, is SVRs. So in the last Q4, so it's much more difficult for us to track that back through previous quarters. But because of the way we've been recording our data, 9 SVRs in the last quarter of the last financial year, SVR 12, which is, again, shows real progress in the work that we're doing. Across the year, we had 16 volunteers trained, went through our 3-day training program. We've got around, it's 5 active peers now. We have people flowing through, getting work. Not all the peers and people we train are up for it. Often it takes that training to realise that they may not be in the right place for it right now. And Kieran is working on a piece of work now, that our ambassador project, which is much more around how can we train and support people who are not quite ready to do full-on volunteering work 1, 2, 3, 4 days a week, but can do it, but want to be a part of what's going on. So we are looking at, we've got a model now that looks at working with people who are actively using, who want to contribute, can't commit, and not ready to commit to kind of more comprehensive kind of worker support. That we can engage them around testing programs, so one-off, or we will kind of support them, incentivize them to find people out in the community, their mates and so on and so forth, and bring them into treatment. So our peer is going to central to that. So what are the achievements here? I won't go through them in detail. I think empowering staff, the feedback we've had, that staff are getting more confident to work and communicate with people living with hepatitis C. individualizing treatment pathways. I think one of our roles within the trust is not just providing direct care, but it's actually working with our partners to help modify some of the pathways that we've traditionally had to treat people and individualize them. And that's where we're getting our success. Testing I mentioned, that's definitely on the up and recording on there accordingly. Retreatment pathways, let's go back to the SVR12s. I think we're trying to find a way to differentiate between poor adherence and reinfection. Okay, and that's crucial in terms of people's second, third treatment episodes, and certainly in establishing SVR12 as a standard of our care is really important. So it's not just around testing and finding people, supporting them into treatment. Our responsibility is work with people until the end of their hepatitis C care. Okay, and that's for SVR12. For some, particularly long-term liver damage, that's requiring ongoing monitoring. We will stay with them through that course. Increased awareness, I mentioned about that. I think certainly all of us here were involved in this process, and Kieran particularly, the CAV Sharing Best Practice event, which was informed by a model we've adapted in England, supported by Gilead, where we have what is called the Providers Forum, where all the key players, all the big service providers, NHS and third sector, sit around a table with representatives once a month to look at how we can deliver elimination. And what's been remarkable for certainly for all of us involved, HEPC Trust sits on that board, is how all these different organisations historically would hold things close to their chest because they were competing with each other, have been so open about sharing good practice. And maybe I'm showing my age, but it kind of reflects on how drug treatment developed 20, 30 years ago. It was a sharing of good practice. And it's essential that we actually do that. So the plan is for having something similar across Wales, and I'm looking forward to that developing. The peer engagement and retention, that's been really notable. I think for the first 6 months, and certainly as part of the national kind of programme, it was quite difficult to engage peers. They didn't really know who we were, didn't understand the work that we did, were less exposed to the kind of volunteer support we're able to offer, the ability to kind of take people to other areas of the country, other areas of the UK, and look what good practice is about. That's really happening, and the quality of peers in Cardiff is notable now. Some fantastic work being done by them. So supporting Wales in the bigger picture here, this is kind of other work. This is the background work that we're often involved in and asked us to contribute to, is membership and representation of the hepatitis B C elimination oversight group and the re-engagement implementation group, where we were, I think it's fair to say, it was recognised that we had an important role in drafting the correspondence, the letters that were going out to patients in terms of that re-engagement process. I'm really proud of that. Our national training lead delivers to 121 staff over the last year across various kind of health boards. That's comprehensive BBV training. And very recently, we're involved, we had our peers, and I need to kind of publicly thank some of the NHS trusts in England for allowing us to release staff to support this pharmacy-led programme. Okay, they recognise the value. We have prison colleagues from the prison team contributed to it, and some of our peers, our Birmingham peers, supporting our programme. Delighted on what was achieved there, which is just as well. All right. Thank you, everybody. Much appreciated.
Thanks. Any questions for Danny?
Really useful.
It's a bit late.
It's only the bus.
So just to say, really, you know, if you can track patients down into the HEPC Trust, they may not know them, but it's worth trying. So I was very impressed. And I'm frightened there's something done.
Can I just add to, and please bring, because I think, you know, we do get this kind of crossover. We kind of pick up a lot of people who've been initially started in Wales and vice versa, by the way. And with that individual's permission, and they tend to give it, we are really happy to kind of share that information.
Okay, any other questions? If not, we'll move on. So next up is Matt Milner, who's going to talk to us about dashboards and micro elimination. So not to steal all of his thunder, but we recognise that if we're going to achieve macro elimination, that means achieving micro elimination. Oh, my computer's frozen. What is going on? Yeah, so we're going to get a talk about how we might achieve that. Which one is your?
It should be your inbox again.
Oh yeah, that's the one I've just tried to copy across now. What did you call it?
I think it might be all Wales meeting.
Okay, let's try again.
I'm ready.
Okay, yeah, sorry about the delay.
So, good morning, everyone. Pleasure to be invited to speak with you today. My name's Aaron Ludlow Rhodes. I'm a medical scientist with Gilead Sciences. The bulk of my work involves working with partnered English prisons as part of the elimination tender in England. Sorry to mention England again, but that's what my role mainly consists of. I'm a nurse and non-medical prescriber by background. Prior to this role, I worked in a national capacity within the English prisons as a bloodborne virus lead nurse. And the decade before that, I worked in community drug services. So always worked very closely with BBV, specifically hepatitis C, and it's great to see the evolution of treatment over the sort of time that I've been qualified. I'm joined today by Matt.
Thanks, Aaron. Yeah, I'm Matt. I'm the National Initiatives Lead at Gilead Sciences, working with trying to link patients from testing into treatment. And again, to mention England, I've probably been responsible for setting up our initiatives with drug and alcohol treatment services as part of the English elimination tender.
So as Brendan mentioned, we've been asked to come to talk to you today about the dashboards that we use at Gilead to measure and monitor progress towards microelimination on the agreed metrics that we have in our partnered drug treatment services and our prisons, in the hope that something similar can be, or the concept can be adopted or adapted here in Wales. And I'm pleased to say those conversations have already started. So I'm going to talk about the prison dashboards that we use, and then I'll hand over to Matt, who will go through the drug treatment service dashboards. So just a quick reminder from the microelimination definition that was published a little over a year ago in the Welsh Circular, the Welsh Health Circular, 100% of prisoners being offered a Hep C test, 90% of those having been tested, and 90% of those who have been diagnosed with hepatitis C to start treatment. So before we look at the dashboards, where do we get the data from? Some of you may know, some of you may not know, but the electronic system or the health records that we use in prisons are called System 1, and the data is extracted directly from System 1. The way that that's done is particular reports are built and integrated into System 1, and those reports look for particular read codes. As Brendan mentioned earlier, computers aren't that clever, so it does rely on individuals making sure that they put the correct read codes. But the beauty about these reports is they can be ran and identify any problems if people aren't using the correct read codes. And a read code is just a code that's associated with an activity. So Hep C tested, Hep C offered, Hep C negative, etc. There's a code embedded into that, and that can be pulled and collated data. The idea is that then those reports can be ran on an agreed timeframe, whether that's monthly, quarterly, weekly, etc. And that enables us or whoever to monitor the progress in prisons. And the beauty of this will be, it'll be a standardized report that will be consistent across all sites if agreed. As I mentioned, these can be run near live, so almost looking at sort of the current status of the prison.
pretty much every evening, with the exception of Sunday. System 1 rebuilds and it collates that information. So if it was ran today, it would look at all the activity that happened yesterday. So you could look at your live population, how many of those have been tested, screened, etc. So if we look at the three metrics, this is how it looks in England, which is slightly different criteria. But again, this can be slightly adapted to meet the agreed metrics when they're set. Here we have, this is based on receptions that come through prison doors. So we can see the denominator is of all those prisoners that came through the door in this example, and I appreciate it's really small text, but I've highlighted it here. There was 471 prisoners received in this prison. Of those 471 prisoners, 456 of them was offered a screening. The dashboard will then calculate what the percentage is, and as you can see there, it's 96.8%. So that's how you could look for the offered metrics in microelimination. Again, when we look at microelimination 2 criteria, this is based on the testing information. So again, we look at the whole population. The current population of this prison when this report was ran was 1,278. Of those, the denominator, the numerator of those prisoners was those that had been screened for hepatitis C. In this case, it was in the last 12 months, but again, that timeframe can be agreed and adjusted. 1,212 of them had been screened, which gives us the percent of 94.7. And finally, this was a little bit more of a challenge to how we would measure those that have been treated. And this is how we agreed, and it's measured in England with the Gilead dashboard. But again, you can slightly tweak this to meet the criteria you agree with. So how we defined it was of the current population, those that had a positive PCR result or positive RNA result that hadn't been superseded by a negative RNA result. Therefore, that gave us the eligible population, so those that potentially could be treated. In this case, that number was 11. And of that eligible population, what we looked at is those that were currently on treatment or had completed treatment but potentially are awaiting their SVR. This gave us a figure of 8. You take one from the other, and that's where we work the percentage out. So potentially there's 3 there waiting to start treatment or potentially refused treatment, etc. But that's how we measure that final one on those treated within the English prisons. So I'll hand you over to Matt, but more than happy to answer some questions after Matt's finished.
So that's all really clever stuff, and I'm not that clever, so please don't expect the same presentation from me. But I did want to kind of bring up again something that Danny mentioned a little earlier, and Danny said that he sat on the drug treatment service hepatitis C provider forum, which is an organisation that, or a forum that exists in England at Gilead Leave. You can see the organisations that are involved in that forum. And I think the huge advantage and why I'd love to see such a forum being created across Wales was that actually trying to take World Health Organization elimination goals in a big picture scenario, and I know Josie's going to talk about that, and it's fantastic to do that. You know, how are we doing as a whole? Sometimes you have to chunk that elephant down a little bit. And for drug treatment services specifically, we said, well, what do we actually mean by eliminating hepatitis C? So we were able to actually come up with some criteria. And again, if I could say, what could you do in Wales to help eliminate microelimination? Is it to deliver microelimination? I'd say, well, let's define it. What do you actually mean by it? It might not be the most scientific sort of criteria, you know, the most accurate criteria, but let's have something that we can actually run towards. Because what that has done in England is meant that each of those organisations are now running towards those criteria. And as they run towards those criteria, we see testing going up, we see referral going up, and we see linkage to care going up. Let's have some ideas of what we're aiming for. And actually, let's have some idea of what we're aiming for that's developed by the drug services themselves. Not something that's imposed on them, but something that they actually would aspire to want to deliver. That's what works. What that has enabled us to do, and we're in a very privileged position, is we were able to ask our partner drug services to say, can you provide us with the anonymized aggregated data that you have, mostly taken out of the MDTMS system? We import that into a Tableau system. This is not patient identifiable, as I say, but what it means is we can see how many people have been tested, who's been tested, how frequently have they been tested, how many of those individuals were testing positive, in which groups were they testing positive, where do we need to improve referral? Where do we need to chase down the people that have been referred that have not yet been treated? How do we follow up on SVRs? So actually having the data set all in one place means not only can we measure how successful we're being, it means we can also put activities and we can put interventions in place to improve those pathways. So every time you see an organisation in England saying we have micro eliminated, every time you see that tweet from With You or CGL on Twitter or X as it is now, they are actually measuring themselves against these criteria. We can then say, at your current trajectory, how long is it going to take you to reach these criteria? And therefore we can say, what do we need to do to improve it? There's some familiar faces in this room, and what I'm really pleased to say is that we've started some initial conversations around, can we do this in Wales as well? Love to talk to you about that, because I think this is something that has been fundamental to the success that we've seen in the stories in England. Thank you very much.
Thanks both. And just quickly to jump on, I mean, one of the beauties of micro elimination is that you can take it further and further down. So it could be micro elimination within a drug and alcohol service, but if you're someone here who has a caseload, it could be your own personal micro elimination. Could you, with your caseload, say, I have now tested everyone in my caseload and I personally have achieved micro elimination. So you know, it's a really important concept, and one that we want to adopt in as many places as possible. And again, as I said at the beginning, it's you guys that deliver. So anyone who takes that on board and takes it back and takes it forward is going to help us move forward. So sorry to just quickly jump on that. Any questions for Matt and Aaron? Yes, please. Oh, actually, could you wait for the microphone? Have we got the microphone? Oh, the one time I remember, they're not ready. Yeah, go for it. Just shout. Oh,
The prisons have such a high turnover.
Yeah.
Sometimes you're short sentence are gone,
Mhm.
and then they're moving to a different area. How do you keep track of them once you've started?
Sorry, just do you mean the prison when they transfer, or do you mean just keeping the testing at high levels because of the
You tested someone, you
Yeah.
tested positive.
right? So I guess there's two ways that can happen. One would be ultimately to do as much as you can in that initial sentence. I think some of the pathways that we've worked with, particularly in our remand prisons, is using an instant point of care test, embedding a Cepheid machine in that process. So actually, theoretically, people are diagnosed viremic within a few hours of walking through the door, and then working with local treatment providers to get the treatment in there as soon as possible. In England, it has to come from hospitals. I'm not familiar with it. I believe it's slightly different in Wales. You can store it on. So I guess if you can start the patient on treatment and that treatment can follow them, we've got the best opportunity for that person to finish it. It doesn't rely on different parts of the puzzle, albeit, you know, I know that SVR. I guess the other part would be utilising our colleagues in the HEPC Trust in England and the Follow Me process. So when that patient first engages in conversations about BBVs, and particularly if they're diagnosed antibody positive, it's getting the consent to share that information with the HEPC Trust, so that if they do move or if they're released into the community, that form and that seek and find mission can be completed by our colleagues at the HEPC Trust. And as Danny mentioned, and I'm sure Lee will be happy to talk to you about the Follow Me process, really good figures of engaging people, picking up on that wherever they got to on that treatment journey, whether it's they hadn't started medication, it's their waiting SVRs and stuff. So it's not a perfect system, and there's definitely gaps. And I think with prisons, there's, you know, midnight security meetings, etc. But I think that mitigates it. And I can see Lee's got his hand up. So
yeah, just time for one more question or point.
Something that have got capacity and that can really affect that number. So I was just wondering if there's anything I don't think this is there's caveats that you really have to make sure that that's taken into account.
Yeah, thanks, Lee. So for the people who are listening online but maybe can't hear, Lee's is asking in prisons there may be people who can't start treatment for legitimate reasons, and how is that accounted for in your elimination figures? It's quite a big topic. I'm conscious of time, so I am going to move us on. But it is an important thing that we have to factor in terms of achieving elimination and targets. But at the same time, I think we have to bear in mind what the targets are there for. They're there to drive us towards elimination. You have to have a target. It won't necessarily be always achievable, but if you're moving towards it, there might be some bumps in the road around people who have got legitimate reasons why they can't be treated. But I don't think that would necessarily impact on our whole eventual target, which is achieving elimination. And there's something in there about wanting to have that elimination status, but not getting so hung up on it that you lose sight of what the whole purpose of testing and treating is. But I am going to move us on, sorry, in the interest of time. Thanks both. Thank you. Okay, great to welcome Josie Smith, who's going to give us an update from Public Health Wales on lots of things, I think.
Yeah, so yes, just to say that I'm presenting, but I am representing huge amounts of work that's been undertaken within health protection in Public Health Wales, both within the communicable disease surveillance, but also in the substance misuse and wider inclusion health teams, among others. So I have been charged by Brendan today to present 4 big projects, major projects, in 15 minutes. So I'm going to sound like a little bit of a radio advert, so forgive me. But we are around all day, so please come and find us for points of clarification. So I'm going to start with the BBV PET tool. PET stands for Progress to Elimination. And this was really a project to really define at a 4 nations level, because we're working at a 4 nations level, where Wales is in relation to those WHO and also wider UNAIDS targets, which I'll come to now. So fortunately, Brenda very kindly went through the indicators. They were updated in October of last year, just to reflect a change in the mortality, which is a combined Hep B and Hep C. For the purposes of Wales, we have kept them separate and also a combined figure, and they have strengthened the mother-to-child transmission indicators. And the BBV PET tool, forgive me, I don't know how it's coming across at the back, but this is the interactive BBV PET tool. It's an HTML, and all of these links are hyperlinks, so you can achieve direct access where you want. But in summary, these are all the indicators for WHO for hepatitis B and C. There are also, as has been mentioned, 3 additional targets for prisons in Wales, which are highlighted. And we've also included the UNAIDS 95, 95, 95 targets on the basis that we are pretty much across the piece testing for Hep B, Hep C and HIV at any one time. So it made sense to do that. And Welsh Government are signed up to that. So as you can see on the right-hand side, where it is green and says WHO, that is, as per WHO definition, we have met it. Where it is red, we have not met it. And in some instances, we've had to use proxy measures because I think, as Brendan alluded to, some of the indicators were really hard to define, and we're still working at a 4 nations level to understand how best to define that for the UK. And then for some of the in yellow, some indicators where the data is, or the data feeds are not currently robust enough for us to be able to report against. So that's phase 3. So you can see for a number of them, particularly the prevention, unsafe injecting blood safety, we are meeting those targets, particularly vaccination, hepatitis B vaccinations, and the mother-to-child transmission really doing well. Mortality, we're kicking it absolutely way below the targets within Wales, but there are a number, particularly around prevalence, incidence, testing and treatment for hepatitis B and C, where there is still further work to be done. Alongside this, and I won't bore you with it, please don't read it, it's not for you to read, we had to produce and have produced a data definition so that there's absolute clarity about what we're producing, what the caveats are around that and what the limitations are. This is an example, and obviously it's an interactive tool, which I can't show you here, but this is just an example. So this is indicator M, annual hepatitis C incidence, so number of new cases per year of less than 5 per 100,000 in the general population. The red dotted line represents the Wales figures, and the blue line represents each health board's progress against that and where they are in relation to the Wales mean. In 2023, the Wales rate was 8.33 per 100,000 population. And each of these, so when you hold your cursor over the interactive tool, it actually gives you the figures per year, or the rates per year in this instance. So retain that 8.3 in your mind, because the next indicator is directly related to people who inject drugs. As we all know, hepatitis C, highest prevalence in people with a history of or currently injecting drugs. And for those of you who have been here before, I'm saying the same thing again. We really, really need to collect risk factor data, not least because we cannot evidence against this indicator if we're not able to identify those people as currently at risk through injecting drugs. So risk factor data amongst people who are in the community and in prisons, recorded on the harm reduction database, so substance misuse, homelessness, criminal justice. That question was only asked for less than 30% of the population. We cannot populate this indicator without that data. And likewise, the incidence of hepatitis C in the general population is overestimated because we cannot remove the population who would fall under this category. So just to say, we have colleagues here, Dan and Savannah, wherever you are, who can show you the interactive tool. Please come and find us at lunchtime. It's much more involved than what I've been able to show you here. My next project was around developments within the bloodborne virus module of the harm reduction database. Many of you will be familiar with this, but Dan and other colleagues have been really working very hard and listening to individuals who are using this in services, in outreach services, to try and better refine the tool for ease of use. So here is itemized the risk factor data for on the bloodborne virus module that was introduced in, I think, 2015. We did work with colleagues, and for any of you who are familiar with epidemiologists, we always ask every question because it might be important at some point. Well, we have realized, and a lot of them are logical, what we have realized is that we need to rationalize in order to speed up the process of testing, to minimize the demands on the person being tested, and also those that are doing the testing. So we have rationalized to remove the following indicators: chemsex, blood transfusion, other risk factors, additional risk factors, blood factor recipients, and accident and occupational assault. All right. So that leaves us with, have you ever been in prison? Have you had sex? Do you use drugs? Simple as that. This is really rationalizing it as much as we can. And that includes injecting and non-injecting drugs. You will bear in mind that harm reduction, fundamentally, and particularly more recently, we need to reduce harms, including death. And the risk of use of multiple substances, along with the injecting risk, is really important along with that. So just to summarize the changes proposed: keep substance misuse, including injecting, sex, and prisons. The sexual risk questions, I know, has been raised as an issue, particularly in an outreach environment, but for people with a range of experience who may not be that comfortable. So we've rationalized that question to be, have you been sexually active in the last 12 months? No, yes. Would you like a self-test STI kit, which is chlamydia, gonorrhea, and syphilis? And we must also bear in mind, for those of you who may say, please can we ask no questions at all? this tool, the harm reduction database, is in a lot of instances the only system where we're recording harm reduction interventions and promoting and prompting those conversations with individuals who may be not willing or readily accessing substance misuse or more formal health services. This remains the only option. So this is our best compromise, but happy to have that discussion further. We will be adding syphilis on the dry blood spot. It's happening in prisons, has been happening in prison for a while, will now be rolled out across. So that's the sorry, that's the harm reduction database. Moving on to the hepatitis C re-engagement project that I think we referenced this morning. Just by way of background, we started way back many years ago, pulling out every test from the laboratory tests since 1990. We excluded those with evidence of an SVR, the definition is there, and phase 1 identified all those that had a positive PCR without evidence of SVR, and then contacted or identified and contacted the GP that was responsible or they were registered with to try to prompt testing within that environment. And the hit rate was around 10%, which was less than hoped, I think it's fair to say. So phase 2, which we are in the final stages of, was of those remaining, so still positive, but in effect lost to follow-up or not engaged actively in treatment. All those with positive and equivocal results. And just some of the data. So we started in this massive look back with just over 3,000 individuals who had hepatitis C, laboratory confirmed, but had not been engaged in treatment. Patients were removed. So the clinical teams, I cannot overestimate the amount of work that's been done by the clinical teams to go back through the records, populate those records, and make sure that what we had left for phase 2 was real. They were alive, they were in Wales, and they were remained untreated. So we started phase 2 with just over 1,500. So you can see here we then searched through data sets, linked data, to try and establish how best we could identify them out with a primary care. So you can see the majority do have and are registered with a Welsh GP, 89%. 50% were matched against our treatment data, so the Welsh National Database for Substance Misuse, or the Harm Reduction Database, or both. So they were currently active and engaged with substance misuse treatment services, and just 9% were not matchable. So next steps. So those 1,500, all of the contact details have been sent back to their relevant health boards, and the clinical teams are now following them all up to re-engage and get through treatment. So next steps for us, the health boards have their data. We did ask for an early return, so the data was issued to health boards on the 7th of December of last year. We've had a brief summary of attempts to contact and follow up so that we can start to pull together progress against where we are in the short term for the implementation group next week. One of the key things that we need to do, and I think probably clinical teams also need to feel that there's an end to this, is when do we finish this project? There was some debate, I think, Michelle, the other day about timing and about capacity, because this is a huge job to look back as well as treat all of those people who are currently coming through the system. But I think if we can have a discussion around that, that would be really helpful today. And also the outcome of this is that when this project is done, it doesn't stop. We incorporate all of those people who are remaining untreated into business as usual. And we need to work with you, with the clinical teams, DHCW, to automate mechanisms so that there's an early alert when you have a confirmed case of hepatitis C, a month later, if they've not been referred or they haven't engaged with services, there is a mechanism to pick that up as quickly as possible so that we don't have a patient group that is in effect lost to follow up in future. But sincere thanks. I can't overstate the amount of work that has been undertaken by clinical teams and others in order to do this. But the way forward is the hepatitis C registry as business as usual. Just to finish then, I was asked to touch on KPI 6. So this is a key performance indicator for substance misuse services from Welsh Government. All those engaged are offered testing on at least an annual basis, and that's Hep C and HIV. This is work that is being undertaken by Elizabeth Walsh, credit to her, developing dashboards. And you can see this lovely space here, that will be KPI 6. So work is underway to update on a monthly basis at health board, local authority and agency level to provide this monthly. So we'll provide a data feed of everyone's been tested. That will be matched against the Welsh National Database of Substance Misuse. And this key performance indicator will be updated. And this is every substance misuse service, be it CDAT, NHS or third sector. And then progress over time. So you'll be able to see the trends over time, specifically against this key performance indicator. As I said, my colleagues are in the room, so please come and grab us at lunchtime if you require any further information.
Yeah, thanks, Josie. And you are spot on. I gave you far too little time to cover far too huge an area, but thank you for doing it so well. Any quick questions? Maybe time for one. Just whilst you're thinking, just to say that KPI 6 is a crucial element of us delivering elimination. So something that I'd really encourage you all to focus on, because it goes back to the beginning that only once we've achieved that will we know what our denominator is in large part. Yes, John?
Thanks very much, Josie. Did patients as part of that second phase, did that have more impact on contacting the GPs?
The first phase with the GPs?
Did you say it was 10% or something?
Yes, so the
Did you write
GPs were, the patients were made aware via their GP socials.
We can pick that up in the break, maybe. Yeah. Okay, thanks. Yeah, I do encourage you, like John's got a follow-up question, but I encourage you all to maybe catch up with Josie in the break as well. Okay, so the next talk I'm excited to see, because you'll probably know from previous events that Rees Oakley developed an accelerated treatment pathway, which has been in our guidelines for many years. But it's to a certain extent relatively easy to write a treatment pathway. What's more difficult is to put it into action. And one of the whole points of this meeting is really to try and get you guys to think about what you're doing and start putting some things into action. And here we have Elizabeth Hurry, who's going to talk us through how she's put the accelerated treatment pathway into action.
Thank you very much. Yeah, so for those people who don't know me, my name's Liz. I'm a pharmacist in North Wales, and we've been doing community clinics now since 2019. So I just wanted to talk to you a bit about that and how it fits in with the accelerated pathway. So first of all, I actually had to look back and see what actually is on the accelerated treatment algorithm, because although we're using it, you don't tend to keep looking back at it. So I wanted to know exactly what it said for both situations and think about how we actually fit in with that. So the preferred treatment algorithm says, first of all, someone with a positive HCV test, do blood. So for FBC, UNI, EGFR, LFTs, AST, gamma DT, INR, genotype, confirmatory viral load, and I don't think Hep B core was on there, but I know that we do that. And then after that, either do a FibroScan or use your blood results to calculate your APRI or FIB4. And depending on the results, either discuss with the team, or if the results are all looking good, then offer pan-genotypic treatment. And then, so the algorithm also says check bloods 2 to 4 weeks into treatment. And then after treatment, 12 weeks following treatment, do venous PCR to check for a cure. So that was the preferred treatment algorithm, but there's also an algorithm for where it's just not possible to do bloods for people or a FibroScan. So for that, it's just the dry blood spot test for the antibody and then wait for the reflex PCR on that to find out whether they're actually positive. And then because we can't get bloods for these people, assess for signs of advanced liver disease. If you think you have got signs of advanced disease, then again, discuss it with your team. But otherwise, again, offer pangenotypic treatment. And for these people, still best practice to do venipuncture 12 weeks after the treatment. But there is also provision in the pathway for if you really can't do that, which is dry blood spot test after 24 weeks, but with the caveat that really that's not a good situation. So wherever you can do bloods, do. So as I say, we've been doing community clinics since 2019. So it started in Wrexham Community Care Hub, which was actually in that building there, which is Salvation Army Church in Wrexham. So they had drop-in sessions every week for a lot of people. So we'd get 50 plus people turning up every single week. So a lot of street homeless and vulnerable people coming every single week because there were multiple agencies there and they'd get to speak to them every week. So we went along as well so that we could do, well, dry blood spot testing. So we're actually testing for everything, but also then thinking about HCV treatment. So doing dry blood spot test for anyone and everyone who would have a test. We had a CEPHID machine as well, so we could get HEPC results back to them within an hour. And then we had to think about how can we, with the accelerated treatment pathway, get people onto treatment quickly. So they were, I'm sure Graham, who's sitting here, will agree with this, they were quite a challenging set of people to get blood tests from. So say a lot of street homeless, so people would turn up and they were freezing, which isn't great for getting blood tests. They wouldn't have had anything to eat and drink, and again, not great for getting blood tests. But despite all that, and despite the fact that we knew we could treat people without bloods, in the vast majority of cases, Graham actually did get bloods out of them. So all credit to him. But there were a few people that we'd sometimes get like partial sets of blood tests. So some things would fail, you'd end up something would hemolyze, you'd get some bloods and some failed. So it was good to have that backup treatment pathway as well, to know that if we didn't get everything, that we could still treat people. So in all cases, we were using pangenotypic treatment. So even when we knew what genotype we were dealing with, so partly that's good because you don't have to wait for the genotype to come back, and it meant we could get people onto treatment more quickly. But also we found, particularly in this environment, it was good to have everyone on the same treatment, because we did come across people who would have lent a tablet to someone because they were in town, or so actually having everyone on, we were using Epclusa, was actually a great situation. So as I say, we were seeing people weekly, so it was great for the accelerated treatment pathway. And they were there anyway, and they just sort of saw us as a side effect of that. But just to say here, and I'll talk about it more later, the pace was very much driven by the patient. So we very much had the ability to start someone on treatment the following week, and we could be there with the tablets. But in some cases, they just weren't in the position to start treatment then. So unfortunately, as for everyone else, COVID happened for us. The hub where we'd been treating people had to close. And we had a bit of a hiatus where we weren't able to see anyone. But then after a few months, we could start seeing people again. So the nurses were able to start seeing people in SMS. Pharmacists were actually dialing in over Teams, which limited the number of people in a room, which was good. And we had to start thinking about how can we work this with appointments, because very much at the hub it was drop in when you want, and how could we work this in a bit more of a structured situation, but thinking about the fact that it had to put the patient first. So it was much harder in those days to get people to support because the key workers weren't always able to come along and things like that. But we still had successes with that. And I think because COVID forced us to give us a bit more of a structured approach, we proved it could work, which meant we were also able to roll it out across North Wales. So we got Health Board funding, and so the map there of North Wales, which shows you that Betsy covers like a huge area. So naturally, we've got 3 hospitals in North Wales. So we've sort of split service across the 3 areas. So we refer to it as East, Central and West. And in each of those areas, we've got bloodborne virus nurse linked to harm reduction. And we've got pharmacists in each of the areas as well as people overseeing the whole thing. So they're able to run clinics in various locations across North Wales. Some people are known positive, so there's some people who are sort of on our hit list, or their key workers will bring them into the service because we already know about them. And we've also had quite a few testing projects. So we've done testing in hostels and hotels where people are staying. There's been some massive SMS testing projects. We've also done some testing in community pharmacies as well to try and find new people to treat as well. So thinking about the accelerated protocols, virtually everyone is getting bloods before treatment. But some people fall a little bit between the 2 policies. So sometimes if someone's had bloods in hospitals recently and there's enough bloods to not worry about it, we don't necessarily do new bloods. Everyone's getting pan-genotypic treatment unless we're particularly worried that they've got resistance, in which case we'll look at that. And the protocol actually says that you're doing bloods 4 weeks into treatment. So in most cases, we don't do that for people. So I think in practice, we're only really getting blood tests for people if their first bloods were abnormal. The only things that we're probably doing at week 4 or maybe week 6 is getting a PCR, because that is very helpful. I think we've found to know that people are taking the treatment, but also for the patient themselves, if you can say your viral load has dropped, I think that's very encouraging for them. And quite often, I think, especially because they're not getting side effects with treatment, they almost don't feel like they're taking it. So to have a bit of success is great for them. So thinking about how the accelerated treatment has worked for us, so over 175 patients have now been treated across North Wales. So that's since 2019. So a lot of them had failed to engage with treatment previously. I think the record for us is one man finally managed treatment after 23 years. And he's had plenty of opportunities to go to the hospital, but he was probably never going to engage with that. It took us several attempts, but after 23 years, we got him through treatment and he's achieved SVR. Also, I think in terms of success, people are now talking to each other about testing and treatment. So we're hearing that people are talking to their friends and people are coming that we haven't even had contact with to ask for tests, which is great. And we've also found that treatment can have impact beyond just clearing the virus. So we've seen people more confident about other things in their lives. We had a man who felt able to make contact with his children again after years of not seeing them. But also, I think positive engagement with healthcare, particularly if people haven't had it in the past, gives people confidence maybe to get other health issues investigated and things like that. So I was just thinking about how accelerated really is. So say we obtain bloods for most people, so we're normally following the preferred protocol. And sometimes halfway between the 2 protocols. And we've very much got the ability to treat people the following week after a positive test in certain circumstances. So we've got a team of nurses and pharmacists, we've got the pan-genotypic treatment and the support available for the patients. So all those things mean that we can start treatment really quickly when we want to. But I thought it was also worth saying that we have to treat the person at the right time for them. So I think there's sometimes a temptation to get people onto treatment because it makes your figures look amazing. But just to realise that actually you can't always get someone to treatment the following week and not to see that as a failure. So I thought I'd just give you a few examples of real patients from our time treating. So patient A is really the ideal person for the accelerated treatment pathway. So he already knew he was positive, but he came along to a testing event anyway, had another test which proved that he was positive. So he hated hospitals and he's been in A&E a few times and felt judged. So because of that, he'd never gone to any appointments for HEPC treatment. But he actually really wanted treatment. Bloods got taken, they were all fine, and we were able to start him on treatment a week later and achieved SVR. So that is your perfect accelerated treatment pathway. Then sometimes we have things that like mess it up a little bit. So this patient B, he came along to an event we were doing where we were giving vouchers and his incentive. So he came purely because he wanted a voucher. when he came back positive for Hep C, it was a real shock to him. He just wasn't expecting that at all. And so he came back to see us several weeks running, and he was crying a little bit. He had a bit of a shout, not particularly at us, but just at life, really. And he wanted to tell us repeatedly how unfair it was that he had Hep C, because he said he hadn't put himself at risk. He thought it was someone stabbing him that had done it. So we had the treatment there after a week, but there was no way he was ready to start treatment at that point. He wouldn't have any bloods because he was just generally annoyed at everyone. But he did have some bloods from recent hospital appointments, so I could see some results. I didn't have enough to do the APRI and FIB4, but I could see that his liver looked okay. In person, he looked okay. So I think he started about a month after we first saw him. And at that point, he really engaged and he took the treatment very reliably. And we've now got an SVR for him. And then just to prove that sometimes there's real extremes. So patient C, so I think we met him for the first time in 2019 in that original project in the Salvation Army. And he came back as positive, but he really wanted a phone at that stage because we were sometimes giving people a little phone just to enable people to keep in contact. And he wanted the phone desperately, but he didn't necessarily want treatment. And he talked to us a little bit in order to see if he could get the phone, but Hep C wasn't high on his list of things. But we spent a lot of time persuading him. One week when we tried to start treatment, he ended up getting admitted to hospital. Then he'd stall a bit more. And then we'd made a real plan to start him on treatment. And then, unfortunately, I think the week we wanted to see him was the week everything got cancelled due to COVID. And then we saw him again in 2021. And again, he came and got tested again, even though I was like, I know you're positive already. And he had his test. And he also got lots of other people. And I think he brought 10, 15 people along to get them tested. He was trying to bargain with us that if he brought a certain number, he could get an extra voucher. But even though he came back positive again, he was just like at that stage, treatment is not for me. He was telling other people to get treated, but not for him. And I think over the years we saw him several times, and sometimes he'd say, I need to sort out my treatment. Sometimes he would just not be interested at all. I also saw him in prison in HMP Berwyn, and we actually started him on treatment in January last year. But after release, again, he didn't engage, even though Becky was valiantly trying to follow him up in the community, wasn't interested and didn't take it. So finally, we've succeeded. September last year, he took the whole course of treatment in prison and he's got an SVR now. So just to say, it works, but it's got to be the right person at the right time.
Okay, we are running a bit short of time. Amazing presentation, amazing work. Really encourage people to speak to Liz and Sarah about everything that they've achieved in North Wales. It's a real example of what we were talking about in the beginning about managing to achieve things within current resource. So really good to see that. And as you were talking, Liz, I thought, you know, accelerated pathway, it is an accelerated pathway, but it's also a low threshold pathway. So perhaps we should badge it as both of those things rather than just accelerated, which gives the impression that we want everyone to run along quickly, which I do, but like, you know what I mean. Okay, and finally, last topic, I'm very grateful to Dr. Susie Froud coming to talk to us about antenatal screening of hepatitis B. And we are a bit guilty of not giving enough time to hepatitis B, so I'm pleased to be able to end this session with this talk once I find it.
Good.
What on earth? Not even on my, I can't see it. Help.
Get a hold of
I know, but I can't, if you come and see what I can see, you'll see why I'm not clicking the button. Oh, I can do it over there. Thanks. Okay, sorry guys, back on schedule.
Thank you very much, everyone. I'm very aware that I can make myself unpopular by coming to a HEPC conference talking about hepatitis B, starting late before the coffee break. So I shall try my very best to move quickly through things. I'm presenting work on behalf of a large number of people. I'm a consultant virologist working for Public Health Wales in Cardiff. And what I'm presenting is in fact a re-audit of the management of women with hepatitis B who are pregnant in Wales. Hepatitis B is as important as hepatitis C because it is also part of the elimination targets. Unlike hepatitis C, there isn't a cure for hepatitis B, but there is a safe and effective vaccine for hepatitis B that's been part of the routine UK vaccination schedule since 2017. Hepatitis B is much more infectious than hepatitis C. If you're a susceptible person was to get a needle stick, your chances of transmitting hepatitis B, if you've got it, are 30% compared with hepatitis C's 3% and HIV 0.3%. It's also possible to transmit it in ways other than blood. It is shed in saliva. You don't have to engage in the activities that you need to engage with to get hepatitis C in order to get hepatitis B. It can be enough to be a household contact of somebody who's got hepatitis B in order to acquire it. It can be picked up by sharing toothbrushes, razors, just living in close contact with someone. Presentations that patients get with hepatitis B are you can have an acute hepatitis and that can be cleared, or you can go on to develop chronic hepatitis. And one of the very, very interesting things about hepatitis B is that your chance of developing chronic disease depends on a number of factors, including how old you are when you get it. So looking at the figures up there, if you get hepatitis B in the first year of life, there's a 90% chance that you'll go on to develop chronic disease. And chronic hepatitis B, like anything that upsets the liver, leads to a cascade of fibrosis, cirrhosis, hepatocellular carcinoma, and death. Hepatitis B is also able to produce hepatocellular carcinoma without the preceding liver disease and fibrosis heading on to that. So this is why trying to address mother-to-child transmission is hugely important. If you can stop that happening, then you can save these patients from the complications associated with chronic disease. And it explains why hepatocellular carcinoma is such a big problem worldwide, because hepatitis B is a global problem. And the WHO estimates are up there. And it says of the deaths to do with hepatitis B, 80% of those have been infected during early childhood, during birth. So it's an excellent group to target. Sorry, big yawn from the crowd there. Only 5 minutes till coffee. Right. Hepatitis B in Wales is less of a problem than it is globally. There are differences geographically and also in sex and age groups, but you can see that people who are likely in their childbearing years are more likely to have hepatitis B. Hepatitis B is diagnosed by a blood test. First thing that you do is hepatitis B surface antigen. If that's positive, you go on to do the other markers, the E markers, the core markers, all those various other things that you may or may not remember, that then allow you to assess where the patient is on their course of having hepatitis B. Is it acute? Is it chronic? Have they got lots of virus around? Are they are they high risk for transmitting or not? Antenatal screening for hepatitis B and for the other communicable diseases that are screened for, which are HIV and syphilis, is to identify the women who are infected with hepatitis B, because their infants are at a significant risk of acquiring these infections, and steps can be put in place and things can be done to protect the children. So the whole aim of it is to prevent mother-to-child transmission of hepatitis B, but it has the side aim or the side benefit of identifying women who've got hepatitis B and making sure that they are treated.
So how you prevent mother-to-child transmission of hepatitis B, fairly obviously, you've got to identify the mothers who have got hepatitis B, and there needs to be robust pathways to manage the results, which antenatal screening Wales has a large number of policies and procedures that tell people what they need to do if they have a reactive hepatitis B result. So your screening test is positive, but nothing else is. And we won't be dwelling on those today. And then what to do if you find somebody who has got hepatitis B currently, what you need to do. And the options depend both on the mother and the baby. How high risk is the mother for transmitting infection? Has she had acute hepatitis B in pregnancy? Is she E antigen positive with a high viral load? In which case you do some things. If the baby is born extremely preterm, then you would go down a different route as well. And the options that are available is to give hepatitis B immunoglobulin, HBIG, to provide passive immunity when the baby is born. And all babies born to mothers with hepatitis B get hepatitis B vaccine at birth. Hepatitis B is part of the routine vaccination schedule, but it's not enough to prevent mother-to-child transmission. So they get an extra vaccine when they're born, and they get various extra ones along the way. This is a re-audit of things that were done in 2017, and the key numbers to remember from there is that 59 women in the year of 2017 had hepatitis B and had babies in Wales. There were various recommendations that came out of that, which we shall skip over because everyone's tired. So the re-audit aims to look at how we are managing women who've got hepatitis B in pregnancy, but we're doing a further step with this audit to look and see if what the outcome is. Were we able to prevent the transmission of hepatitis B to the babies? And what we did is we compared the clinical practice to the guidelines that existed, and we found our women by looking at the laboratory database again of all those women who had surface antigen positivity with an antenatal clinic requesting location. So the year that we looked at was 2021, and in this year there were only 23 women in Wales who were living with hepatitis B who became pregnant, which is a significant fall from 2017, and I'm sure we can all come up with various reasons as to why people may not have wanted to bring people into the world in 2021. But from this 23 women, 7 of those were diagnosed with hepatitis B on the basis of the screening programme alone. It is effective, it picks up people with HIV, syphilis and hepatitis B that wouldn't know that they had this were it not for the antenatal screening. There were 16 women who were previously known to have hepatitis B, and if you're known to have hepatitis B and you're pregnant, one would hope that the midwives would do the appropriate tests when you first have your booking appointment. The viral load is the test that is needed, and you should at that point be referred on into care. The viral load at point of presentation is not done very often. What is needed for all serological diagnosis is you need a repeat sample to confirm identity and to check that everything's all right. And the time at which that is done has improved now when you compare to the 2017 data. So we're getting more of that, and we're getting more viral loads. The important thing is then the referral of the woman to an expert in managing hepatitis B. So the referral into gastroenterology and hepatology. And we've got there the figures from 2017 and also 2021 that shows that things have got worse. It shows that there's no evidence of referral for half of the women who have got hepatitis B. And I think this is actually a quirk of the audit and the question that was asked. So is there evidence of referral? Was a referral letter made or found by the midwives? And it wasn't there in 50% of the time. But there was evidence for a much larger number when looking at if they'd had results sent from a hepatology location. So I don't think we need to panic, just be aware of limitations through all audits. With women who were previously known, some of those were not seen in services. And then looking at what happened with the review, which we've got more of than we had evidence of referral, so sorry, is how quickly it happened. And those with a new diagnosis, half of those were seen within 6 weeks, half of those were seen later. Those who are known to have diagnosis, the time at which they are seen by their specialist teams may not be quite so crucial, because if you know that they're at low risk, then you don't need to see them again to check that. The UK HSA, on which Antenatal Screening Wales base a lot of their guidance, did have 6 weeks as the standard that every woman with hepatitis B needed to be seen by a specialist. And they've recently revised that, saying that only those who are at high risk need to be seen within 6 weeks, and those who are lower risk don't need to be seen that quickly. And it'd be interesting in the no time that we have for questions to hear what your thoughts are on that. So post-exposure prophylaxis, those women who are at a very high risk, you want to give their babies the immunoglobulin. So that was indicated in 2 babies. So we had 23 women who were picked up by the screening programme, and we only ended up with 19 babies. There was 1 miscarriage, there were 2 women who we knew left Wales, and there was 1 woman who was entirely lost to follow-up. When immunoglobulin was indicated, it was given on time in both cases. The other thing that is given to all babies born to mothers with hepatitis B is hepatitis B vaccine, and the first vaccine was given on time for everybody. Hooray! This is because most births, well, all of these births would happen in hospital, and you know when someone is due to have a baby, so it is the vaccine and the immunoglobulin, if needed, are made available on the delivery suite, so it's very easy to get the first one done. Things are less easy as time goes by to make sure that they attend the appointments, because it's the routine vaccination appointments that they have, but they also have extra vaccination appointments. And the dark blue bar there shows how often it was given on time at each of the times that the doses are needed. The green for go shows when the vaccine was not given. So not all of our babies received all of our vaccinations, and this wasn't a surprise to us. This reflects practice and what we all know and expect. So we know what has and hasn't been done. Has it been effective or not? One of the big challenge, well, a huge challenge is trying to get huge in a whole series of huge challenges, not just they have to turn up for the vaccinations, but are the babies being bled? It's not easy to bleed babies. It's not easy to bleed them, at sort of the right time between, 12 months and 18 months. But of the 19 babies that there were, 16 of them were bled, which I think is much higher than we were all expecting. And all the babies that were bled, they were all negative for hepatitis B. So we can say when we have enough data, we have proven that we are preventing mother-to-child transmission of hepatitis B. There are, of course, some recommendations that come out of the audit that I'll gladly talk to somebody about later on over coffee if they want. So I'd just like to thank you for letting me talk about another virus, and sorry I'm late.
Yeah, thanks, Susie. Amazing and really important work. Obviously, preventing hepatitis B transmission has a huge impact on the individual. I'm conscious that I've also, as well as asking people to fit too much into too short space of time, I've asked you all to hold on to your bladders for a long length of time as well. So I think I'm going to close the meeting down now, and we'll come back at 11:30. Enjoy the break, have a chat with each other, and catch up with some of the presenters. And thanks to all our presenters for a great start. Thank you.